So great to see you all. I can tell you're all ready to learn, and that's why you're here tonight. So thank you for joining us. My name's Erin Gallardo. I'm one of the co-owners of Neuro Collaborative, and we are here tonight because we love doing these educational events with all of you, neuro PTs, OTs, assistants, fitness professionals, anyone who's curious about doing neuro rehab a little better, learning and collaborating with the community. And we have events like this every once in a while, but all the time inside NeuroSpark, which is our mentorship community where you get continuing education and you learn all the latest tips and tricks from the research and how you can better your practice and your patient outcomes. So tonight's talk is going to be on navigating treatment for people with ataxia. We're going to show videos, we're going to have ideas. We have a huge community here to brainstorm all together. So it's so good that you're here. And you're going to be hearing from three of us tonight. JJ Maudertini is going to start us off, and then Claire McLean is going to go into the next portion, and then I'm going to wrap us up in the end. I'm so glad that you're alive because you will have a chance to win a Blaze Pod starter kit. So we're going to be giving that away. I'll tell you how you can have a chance to win this awesome Blaze Pod starter kit by the end of the webinar. It's a almost $300 value. So very cool that we have this prize. I'm excited to give it to somebody who I know will make really good use of it. And just as we're getting started, I know you're all saying where you're from. It would be very helpful also if you can rename yourself on your Zoom account. Make sure we can see your full name and your profession, if you're a PT, if you're an OT, what setting you might be in. It just helps us to know who we're engaging with. So we would love for you to do that on your Zoom screen so that we know who's with us here tonight, because there's so many of you. So without further ado, let's go ahead and get started with our first speaker, Dr. JJ Maudertini. And
Alrighty then. All right, I got you. Just trying to set my screen up. There's a lot of you out there, so I've got backup to check the chat as you guys are coming in. Welcome. Very excited to have you here. And we get excited, to pick topics and do our best to give ideas. And that's really what we're focused on. Ataxia, I think, is one of the hardest ones, which is why it keeps coming back around, because the research is a little bit of slim in regards to the direction to go. So really trying to have some of those ideas. And I really want to highlight a few different things in my first part of the talk. And then I have some videos from Sparkies, from friends, and I know that Claire is going to show you a bunch of videos as well with different treatment ideas. So hopefully everyone feels like they can go away with a new thought, a new idea, which is always the idea. So first I wanted to shout out, I'm going to give some shout outs tonight if you don't follow Vestibular First on Instagram. They did a really nice post this week on cerebellar stroke versus progressive cerebellar ataxia. And so I really liked how they aligned it. They did, let's see if I can get my, oops, that's not the one I want. My laser pointer up here. So if you can see in the middle here, this crossover between the two, from gaze-evoked nystagmus, abnormal saccades, dizziness, slurred speech. So we have these different types. We have cerebellar ataxia, we have sensory ataxia, vestibular, Friedreich's, hereditary, spinocerebellar, so it keeps on going, and it just makes it incredibly challenging. So we keep our eyes on some of the different specialty areas that can really help us out. And I think vestibular is one of those systems. So we know it's going to be a longer prognosis and it's going to be more challenging, but how can we put those pieces together and try to see how does our patient respond to different options? So yeah, you can go check this out. So it's not as blurry. It's a screenshot that I took, but go to Vestibular First, their Instagram. They also did a nice podcast, and I'm going to do a couple podcast shout outs tonight from the I Love Neuro podcast. Claire and Erin do such a phenomenal job with that. And there's just so much that you can learn. So mastering the vestibular system, but that's a great resource. And so tonight, not only do we want to show ideas, but we want to give you more and more resources. Sorry, I was trying to read the chat. But like I said, there's a large variation in the types of ataxia, from the age ranges, from the prognosis. So I guess what I'm here to say is that we're all doing the best we can. We need to try to find ways that we can challenge our patients safely, different positions, but we want to make sure that we're sticking to the individualized approaches so that we can improve their quality of life. So we need to be very specific, since this diagnosis is so challenging, that we're very specific on what are the top priorities, as well as looking at different outcome measures. So obviously there are more measures than this out there. When you look at the ICARS, the International Cooperative Ataxia Rating Scale, I just kind of gave you a chart so that you can reference the domain that it covers. It's comprehensive, but it's lengthy. And so, there's no perfect solutions here tonight. And actually, just saying, in neuro, there's no perfect solutions. There's only trade-offs. So this is one that's up there. I would highlight the SARA as well, mainly because it's just a little bit quicker and reliable. And if you're out there working with patients with ataxia, we have to make sure that we're doing some type of outcome measure that actually is made for assessing someone with ataxia. And so that's going to help us communicate, especially when you come up with different types of interventions that are beneficial. This latest research, or for me, and so you can put in the chat if you have utilized this, if you're more familiar with it. But I just found it interesting because I think it was a 2021 article looking at the scale for ocular motor disorders in ataxia. So no, there isn't a way to make the slides if the image is blurry. Is this blurry for you all? Okay.
It's not
So-
right for me, so I don't know if maybe it just needs a minute or it's an internet thing on some users' part.
Yeah.
Sorry about that, guys.
Okay, just checking. So the scale for ocular motor disorders, I think the big piece that I wanted to add this was, looking at ocular motor, visual tracking, and saccades, is that component of when you're looking at the interventions that you're doing with your patient, is there something that you can add? Are you taking into consideration the ocular motor, visual tracking, saccades? Because it's not, if whoever assessed it, if it was OT or PT, I don't care. So OT, I'll go to my OT because I consider them better specialists than myself in regards to vision. And then I'm going to ask them what they found. And then I'm going to try to integrate that and reinforce it in the interventions that I do. So just being aware of the impact that there commonly is for people. And then the other one I just wanted to bring up because I saw a more recent research article in 2021 where they specifically looked at the dynamic gait index for patients with cerebellar ataxia. And so they showed that the DGI was reliable and valid to be used in the clinic with cerebellar ataxia, because it had good inter-rater reliability and test-retest reliability. So we know that when you're thinking about balance and falls, that's our top priority. Our heavy hitter is trying to keep our patients from falling. And so we want to make sure that we're able to assess that comprehensively. So if you're already doing one, if you're doing the ICARS, yay, great for you. If you're doing the SARA, you can put in which ones you tend to use. I would make sure though that you're using the SARA, that you're looking at some of these other pieces, and then you incorporate the dynamic gait index if you're looking at balance. The other thing that I wanted to put out there is, thank you, Jen. This is using the SARA, is that I found the Ataxia Global Initiative, and I'm not sure if people are utilizing that. I'm trying to put it in the chat. It's doing weird stuff. So looking at the Ataxia Global Initiative, you can follow the train of the references down here, but they do have some training for the SARA that I didn't know was available, and then also the scale. But I'm not sure if we provide a scale or not. And I do have the handouts. I forgot to give them. I'll give them after I'm done talking. I'll post it, or I'll send it over to Danielle. Okay. So looking at some of the approaches, so I'm going to highlight some of the research and then I'll show some videos. Fall prevention and intensity are going to be your top heavy hitters. We're trying to prevent falls. We need to do that by increasing intensity via the heart rate best that we can. Some of them, it's really hard. They're moving all the time. And so we have to make sure that we're doing it safely, but we can't just do that. we need to make sure that we're looking at their aerobic and their strengthening and their balance as well. So we're trying to put this into a comprehensive picture, because one of the most important things that we need to do is look at their individual needs. We are not, with the slow progression of improvement or the prognosis from an improvement standpoint, we can't try to do a lot of a bunch of different things. We need to pick the biggest heavy hitter, and then we need to go all in and make sure that we're doing it where we can reinforce their strengthening, as well as trying to increase intensity the best we can, and if not, their challenge as well. So let's look at a couple people here, some individual needs. So I'm going to show you a person, my friend Lauren, shout out to her. She sent me some videos of someone she's working with Friedreich's ataxia. And this was a unique approach. Not a unique approach, but a unique need, potentially, is that this is the Hoyer that she uses. Now, her shoulders are not stable enough to really make sure that we feel confident in regards to this transfer. So what Lauren's been doing, you can find her her Instagram there, and you can see on I Love Neuro podcast, she did episode 221. So I thought that was super cool on wellness programs. So she does a lot of working with people as a wellness program. So really looking at providing that proximal stability so that when she's hanging on those, she's safe. So focusing on our ability to do that, starting with open chained activities to really get that proximal component in the shoulder blades, so she can do that one on her own, while then working with her to do press go to closed chain activities. Add the weighted vest, that's the weighted vest right there, but go to closed chain activities and really try to get activation, progressing to different types of challenge, isometrics and eccentrics. Now, if you're having a hard time doing that, the environmental considerations, some things that have worked. I'll show a couple videos using activator pulls. The abdominal binder, I just saw, shout out to Ray, sent me a video of someone. I was like, oh, have you tried the abdominal binder? Because she's so scared, and really provides proximal stability so that you can then challenge them more. That's what we're trying to do. Adding more sensory input, tying that TheraBand tight. If you don't have a weighted vest, what other options do we have? Weights on the gait belt, give them more sensory input, stabilize them so that then you can challenge them more. Then you can go to stairs if you're working on transfers or whatever it may be. Or adjust the environment by using a harness or a corner of a room or back of a couch or the floor. The floor is a great place to go because then there's nowhere they can go, and Claire's going to talk a lot about that. So if we want to see change with their balance, this great research article by Amy Bastian and Keller looked at, we really need to provide a significant challenge to that person's balance to see change. And so one of our Sparkies, I mean, being a Sparky, being part of NeuroSpark means we're a part of NeuroSpark. So, you know, being a Sparky is just a great, we help each other. So one of the Sparkies reached out and said, hey, JJ, I have this great person that I would love to share. Could you use some videos? And I'm like, yeah, I'll take some videos. So this is Junior and his mom, Angela, and our Sparky Grace, shout out to Grace. So he has a ataxic CP, and he's 10 and a half years old. Their priority is independent tub transfer. So step one is, what is the priority, and finding that out. I added and be a boxing champion, because you will see that, you know, using these external cues, giving him more stability, having him right here, she's having him pushing. So doing a lot of pushing, but doing it in kneeling in a position that he will use for tub transfers, and pushing to get proximal activation, using quadruped, but using externally focused cues so he can keep his shoulder blades closed chained, weight shifting, then adding targets. And watch, she's just, sometimes it's easier with young children, obviously, because they're a little bit smaller, for you to feel safer about just letting them struggle. Doesn't have to do this part. He needs to figure out, what does his body feel like? How can he do the movements? And she lets him do that just beautifully. And I'll show another video in a second that I think is really amazing. But I really like this idea here where you have these different cues, these different externally focused cues. You're getting weight bearing. You're getting in a position that he may need to be in to get into the tub to be able to do these motions. And so she's providing stability, but she's letting him figure it out. And so I'll show another video here in a second. Someone was asking about getting up off the floor. Another Sparky, because we love them so much. Joy, she does some great courses on activator pulls, and she's taught me a lot. So I'm really pretty excited when I shout her out because I was really underestimating these. So there's a great podcast if you're interested in learning more about those. But I appreciate Joy for sharing couple videos that she has showing, again, we're going to go closed chained, we're going to go stable, but if we can take them up to the challenge of getting down onto the floor and back up, because again, we're worried about falls. So constantly practicing getting up and down, progressing him to wearing a vest, progressing him to where you're adding some resistance potentially, break it down into a part task and try to do it repeatedly. Don't forget though, and this is what I don't think I did enough of adding some kind of visual cue, something they can focus on. So focus on a point, add some breathing, and try it again, and now try it again this way, and now try it again this way, and then have them choose what did they feel was really most beneficial for them. And this going up into closed chain and crawling kind of up and then doing a side sit down is just a beautiful choice. So I love that video. She's also showing how you can use the activator pulls fully up. But if you break it down, I think Erin gave away some free ones today. I mean, that lip right there gets more latissimus activated. You can use it in different positions. You can use it. So it's pretty cool. But I really like this idea of trying to do this higher level activity somewhere safe where you're using the mat, right? And then you're just going slow and steady, but you're allowing him to just feel it and get some input. So challenging, you're getting more proximal strengthening. You're challenging him. It's a functional position. If you have the ability to have a harness, which a lot of you don't, right? So that becomes challenging when you don't have the harness perspective. But we have to figure out how could we, if you didn't have a harness, how could you allow him to come to standing and let that happen right there? Let him take multiple steps. Obviously, we need to keep them safe, but we need them to experience that a little bit. So when you see him do it again, I may try to add some type of cue. I may try to add a visual component. But just for him, we didn't do any of that. We just asked him to do it again. He does well when he focuses on his breath, right? But we let him take those few steps instead of stopping him short. So instead of stopping him short, we allowed him to do that. And then he got that. Now, that's not going to carry over. You got to do it again. You got to do it again. And then you got to do it again. And so sprinkling on some of these ideas of thinking of externally focused cues. What cues are you using? How are you using their breath? And, when someone was just emailing me, it was just like, she's so scared. I mean, who wouldn't be? So incorporating those pieces. I just have to show you Junior. This one was one of my favorites. So Junior took a nosedive. I'm leaving the volume on so you might be able to hear it.
10, 9, 8, 7, 6, 5, 4, 3,
Yay!
back out here.
So a very big theme of boxing.
Should we find the other one?
But, using a cue like that to motivate, to get him to come back up into, great, a shout out, Grace. That was just so awesome, and so many visuals. I know we need to do some of those pieces as well, but if it makes sense to someone, that's where we're going to get our biggest bang for our buck. And when we think about, okay, we need proximal stability, we need to challenge them, but we have to make sure they're safe. We think about, okay, what about assistive devices? And we're going to have to use them, but I would suggest trying a few different ones. Because, you guys can put in the chat, what type of assistive devices are your favorites? What do you tend to use? I think typically you see someone who's walking a bit like this, and we might go straight to a rolling walker, which is okay. I'm okay with that. I understand that we need to compensate, right? We've got big problems. Now, he doesn't like a rolling walker. We want to give him more stability. I'm not sure I would have tried the poles before because I would have thought, oh, coordination, oh, this, but he was a hiker. And so, Ariel, that's great. The U step, absolutely. And Nikki, the trekking poles. So looking at this one again, what is that? Because he was a hiker, it really kicked in for him more automatically. And so I guess that's what I'm trying to say in my section is we all would agree this is extremely challenging diagnosis. I think we all would agree there isn't one right answer for these, right? We have lots of different ideas here. I think that we need to trial different things and be willing to kind of see and get the patient's input, the person's input in regards to what makes most sense for them. And the more that we do that, the better. So many younger patients that refuse to use a walker assisted device, I'd love to try the hiking sticks. Yeah. And the reason I specifically like these poles, I know I'm telling you about this because we can, but is that they have the little lip. The reason I'm sold is so that you really can push down if you haven't used them before, to really get some more proximal activation. So I'm gonna just go through this slide for a minute and then I'm gonna pass off to Claire because she has some amazing videos to show you. Natalie, a great question. Why the poles versus the loft strands? I'm going to answer that right now, just because I happen to see it. But consistently what I found is that for the loft strands or Canadian crutches or forearm crutches, whatever you call them, and it depends on what kind you get, but the old type, generally you have to stand up and you have to maintain your balance and you have to get your arm in there. And people really do not like that because you have to be balanced enough to do something with your upper extremity. So, but depending on the kind you have, I would say everyone should kind of, if you can, have different options so that you can try and compare and have them rate and have the patient have some autonomy within the choice. So when I'm thinking the research, and so I gave you some references on the next slide, and essentially the literature went every direction. Okay. So I was trying to kind of give a summary of what would I start with. And really, we have to think of those things that they can do at home repeatedly because we need lots and lots of repetition. And this is going to take a long time, unfortunately, because the cerebellum is so, so important for what we need for movement. So what can we figure out that would be realistic from regular physical activity for them? And this is from the research, and they had extra games, different virtual reality games. When they're with us, or maybe not, depending, Claire's going to show something that they could do on their own, is the overground walking and treadmill training. If they can do that on their own, when they're with us, we want to work on balance. I mean, if they can do that, we want to do this. Consider the visual integration and some of the gaze stabilization components. Kind of try to sprinkle that in and see if adjusting that focus or prepping them and working together as a PT and OT team would help you so that you're doing that consistently amongst both of you. Consistently in the pediatric literature, more specifically, but trunk stabilization and proximal strengthening, they need that more than anything else. And so we have to try and incorporate that while we're doing these other activities and while we're trying to reinforce some kind of high intensity component to that, as safe as we can, but as challenging as we can do safely. That's one of the bigger challenges, right? So I'm going to pass off to Claire, and I will make sure my handout gets to where it needs to go for y'all.
Thank you. I will share my slide. All right. So now thank you, JJ. That was all such great information. And trying to take that and now focusing, JJ showed, a number of different patients and clients with ataxia, showing you a range and some ideas. And now I'm going to focus in on looking at one person with a number of different activities and over years. My name is Claire McLean. I'm a board certified neurologic specialist, co-founder of Neuro Collaborative with Erin, and founder of Rogue Physical Therapy and Wellness. So I really specialize. Rogue is a wellness program for people who have Parkinson's, but I have this client, Patty, who I've been working with for over a decade. And I also was thinking about it in our membership for people with Parkinson's, we have 4 people who have ataxia. So part of me, when we first were picking this topic, I just felt like, wow, this is a diagnosis that I don't have that much experience with, especially when I compare that to how much experience I have working with people with Parkinson's. But then I was like, well, actually, between the years I've been working with Patty and the other members that we work with, I have more experience with working with people who have ataxia than some other diagnoses. In addition to loving working with people who have neurologic diagnoses, I really love brainstorming ways for people to have ongoing access to therapy and exercise, because I think one of the biggest limitations that people face is insurance coverage and how long they might actually have access to therapy for. And for most people with ataxia, this is a lifelong diagnosis. This, in most cases, is not something that's going to go away or be completely cured. This is something they're going to live with. Depending on the diagnosis, it may be something that's relatively stable and can get better. For people who have spinocerebellar ataxia, it may be something that is progressive over their lifetime. So they are going to need ongoing support and therapies. And we want to brainstorm how to be able to do that with people. And we want to implement whatever research does exist into the real world. All right, so this is Patty, as I mentioned in that photo. So she experienced a cerebellar aneurysm in 2011. At the time, her family was told she likely would not survive, but she did. She was in the hospital, had inpatient rehab, was in a skilled nursing facility. I met her when she was referred and did outpatient therapy, physical, occupational, and speech therapy. She did that for 2 to 3 months. And when I first started working with her in outpatient, she could not even sit unsupported. She had vertigo and was dizzy constantly and had severe ataxia. After doing the individual therapies, and she made a lot of improvement during that time, but she and her husband knew that she needed more. And so at that time, I started working with her once a week in her home. So I have been working with her on a regular basis, probably since, I don't remember exactly what month in 2011. So sometime in 2011 or 2012. So like 13 or 14 years at this point in time. So I've known her a really long time. I'm not actually the therapist who's working with her right now, but she's still coming in and exercising. It was really amazing. She got to the point after a couple of years where she was independent with a walker, walking around her home, going out for visits. She really made so much improvement. She then had a second stroke in 2018, left CVA that affected her right side. And these 2 strokes together have made it very difficult. I think if she really had the symptoms of one or the other, we could manage that much better. The 2 of them together have made it challenging. So at this point, she does use a wheelchair for mobility. She is able to walk with a 4-wheel walker, but she does need someone to be there right with her for safety. She is not safe to walk with a walker right now independently. We're working on it again. We're trying to have another comeback. Of course, then we had, COVID and didn't get to exercise together for a while, et cetera. So just reviewing with JJ. So tonight, again, we are trying to pack in as much information in a short amount of time, give you all some good ideas. I obviously cannot cover everything that has occurred in the time frame that I've been working with her. It has been a long time, but I can tell you right from the beginning, like JJ mentioned, the home exercise program was a huge focus for us right from when we were working together in outpatient. And as I continued to work with her 1 time a week on an ongoing basis, seeing her 1 time a week, I knew we are not really going to make progress unless she has a great program of things she can do on all the days of the week that I am not here. So that was my main focus, is figuring out what we can do and actually having a lot of that be what we did in our sessions initially to make sure she could do that well at home. And then at a certain point, when she was really good with her home exercise program, we could transition and continue to progress the activities that we did together and do things that were not safe for her to do on her own. So for her home exercise program, she was very fortunate that her husband was happy to get her a setup at home with a harness that was connected in their garage. So I know this is not a possibility for everyone, but there are treadmills that are relatively inexpensive now. People can do a setup with a harness, get a contractor or do it themselves, use anchors, ropes that are appropriate. This is a construction type of harness. And this is something that I've had multiple clients and patients over the years do and have a setup for at home, often in a garage. There are lots of treadmills now even that fold up and can be stored out of the way. And just thinking about how can she spend as much time as possible upright, in standing, walking, and not sitting in her wheelchair. We need to retrain her postural system, her vestibular system. We need to retrain everything. So we're really fortunate, and I'm sure that has contributed a lot to her success. She, since this photo, has actually gotten a new treadmill one year for Christmas. This one was not the smoothest, so the new one has really been helpful in having even smoother walking. We also knew we needed aerobic exercise, and her walking on the treadmill is aerobic at times. Sometimes it is not, sometimes it is more skilled. So she also has a stationary bike at home, which she uses to get her aerobic exercise. She rides that nearly every day. She has her treadmill set up at home. And then we have our functional mobility practice, which primarily was exercise on the floor. Even sitting, in many cases, makes me a bit uncomfortable when people are at risk of falling out of a chair in sitting based on balance impairments. That is a higher surface than that they might have a neck injury or a head injury. So I'm really a huge fan of functional mobility on the floor and progressing from there. We did a whole webinar last time about getting down on the floor, why, how. You can check that webinar out if you would like to. But you'll see I've got videos of the exercises we do on the floor, so much good stuff. So on the treadmill, I just wanted to show, here she is walking. This is a video that is after the second stroke. I have videos from both before the second stroke and after, but this is after. She has more weakness on the right side now. Whenever I have someone, on the treadmill, it's not just walking. We have a whole standing balance, strengthening balance routine that they also do. We're going to take advantage of being in that harness and just try to spend more time in standing each day. If you work with someone one time a week and you're up moving around, but then the other, however many hours there are in a week, they have to be sitting, using a wheelchair for safety, that's really going to limit their ability to get better. So I, really need a setup that people can spend more time up in standing to recalibrate their system. So we're working here on control of her step. So we have a whole repertoire of exercises, a couple different plans that she rotates through for standing exercises that she does in addition to walking. Here are some of the examples of things that she does at home. Here we're exercising together at the gym, but we would record on her phone the exercises. And then we had, again, ABC program on her phone of where we saved the videos. And so she could rotate through the exercises that she was doing at home and have a few different ones. So we're always doing them together, figuring out, is it challenging enough? It's going to make a difference. Is it safe for her to do? If so, great, we record it. This is part of your plan now. And as she's getting better, we are getting rid of the easier exercises that were previously a part of her plan. So also, I think in a lot of cases, we think of seated and standing balance. And I want you to think of all the different ways that you can challenge balance in all different positions for people. So there in sitting, you can see facial expression. She is working hard. Here we're coming up into tall kneeling, working on transitions. Again, her facial expression, she really shows you what's happening. She's working hard, just like JJ's example of the gentleman getting up from the floor. That first one, she tilted back and made a correction, and she got better immediately. We have to allow people to be in positions where they can figure things out for themselves safely. I truly think that that is one of the most important things that we can do as therapists, is set people up to figure things out, because that is the skill they need to live their life every single day, every single hour that we are not with them. So here, progressing to half kneeling. Half kneeling is way harder than tall kneeling. This is between after the aneurysm, before the second stroke. Oh, and she falls over. I kept that in. Part of why I love working on the floor is because it is safe. Of course, not every single person would I get up into half kneeling like that. We have progressed up to this. She is learning how to tumble and roll around. We're doing lots of changes in position. I'm not saying start with this, but starting on the floor, prone, supine, back and forth, supine into sitting, back and forth, prone, up onto hands and knees, back and forth, and then continuing to progress up from there, depending on the person, what their capabilities are, on potentially a bigger, thicker mat for even more padding. We actually have kind of the padded helmets, and we have other, padding for body parts for people, in addition to trying to practice and improve on balance so that we are reducing risk of falls. We also, it may not hurt for us to actually train people to be able to fall better, because maybe we're not going to be able to prevent 100% of falls, but if they can fall athletically and not get hurt, there will not be as significant of consequences from that fall. So this is kind of showing what her home exercise program was. In terms of equipment, this was a walker that she got, which I think they might not be selling this exact one anymore. I was looking last night trying to find their website. They have a Facebook, but the website didn't work. This was called a Dash Away walker, and it was fantastic for her, really stable. She used this for quite a while and was able to progress to a 4-wheel walker. But again, just knowing that there are different types of walkers out there. If you're in a facility that can have a variety for people to try, that's great. Maybe connecting with local medical device stores in your community to see what types of equipment they have. And if you aren't able to have everything, have a place that you can refer people to for them to try it. So we had a really good home exercise program going. She was doing it regularly. She was on the bike to get her heart rate up. She was on the treadmill to work on her walking and balance in the harness. She was getting it down on the floor, working on all different mobility. And then, okay, now we can progress in our one-on-one sessions to do things that I may not be having her do on her own at home because it may not be safe. We're going to do more things up and standing, but let's see if we can be, as efficient as possible, getting in high intensity practice, dynamic task practice, trunk stabilization, proximal strengthening, visual integration. Can we do all those things at the same time? Maybe we can. So our one-on-one sessions was a variety of walking both on the treadmill and over ground. In some cases on the treadmill, I was facilitating and helping her achieve the best quality walking possible with the best kinematics. In some cases, I'm pushing the intensity for her and going faster, really trying to find a balance, not expecting her to walk perfectly all the time, but also not going so intensely where it is uncomfortable or we're at risk of, an overuse injury. And then we would do overground gait training every single time as well, with and without assistive devices. Her goal was to be able to walk without an assistive device. And although we are far away from that currently, it's still something that I want to, give people hope of what is possible in the future. And so we're going to work on those types of things as well. I do not have very much video of that because it's hard to take video of yourself while you're walking with someone and it may not be safe. Quite a bit of standing balance activities, sometimes with me guarding, with, holding on, sometimes not holding on, sometimes in the harness on the treadmill, sometimes away, lots of that as well. And then progressing with our functional mobility over time. Here are some videos of our gait training. So this was not too long after she had the second stroke. Initially, she really had significant weakness on that right side. And I did have to provide support for every single forward step. We got to the point where I didn't have to do that with my arm. And sometimes I used my foot to give her a little bit of assist for that forward progression. So we started with walking laps in her home. We progressed to walking laps out of her home. Let's see, is it gonna, nope. I don't know how to get it to go out of that video and go to the next one when I make it full screen. So this is her more recently. You can see much better forward progression on that right side. She really requires very minimal support, but is not safe to be walking on her own. Practicing forward and backwards, stops and starts, changes in direction, changes in speed. Again, giving her a bit of support, but also trying to give her as much freedom as possible. And one more example. So here's at the gym on the treadmill. Her treadmill at home did not have incline, so we also would do incline for strengthening and foot clearance. We would definitely do times of one or both hands off, but that is not something I was able to get video of because I would need to be there behind her for support when we try to go one or both hands off. That is significantly more difficult for her. Here's an example though of other things that we would do. During our gait training, we would do gait training for 5 minutes, then do some balance exercises, more gait training, balance exercises, really trying to, push the intensity with the gait training as well to get her heart rate up and then work on those skills and put that all together. And then you could see there, we were working on progressing in terms of reducing that amount of upper extremity support. Here, using the Balance Matters mat, trying to really improve her awareness and weight shifting, getting a heel click and a toe click. Here's our functional mobility, really trying to incorporate everything all at once together at home. For anyone who utilizes the power moves that are designed for people with Parkinson's, they are also really great functional exercises to utilize in people with other diagnoses as well. Here, JJ mentioned, using a piece of furniture like a couch. So here we're doing some steps, and now she's going to take a hand off and keep going. So we're reducing that upper extremity support. You can see it definitely got harder for her, but she is still able to do it. Nope, escape doesn't want to work. Okay, there we go. If I let it play the whole way, I just can't make it go any faster. Up into tall kneeling, working on balance, side to side. We would always make sure that we were in open space and not too close to any furniture because we would have tumbles at times. Okay, that one didn't go out. Core strengthening, proximal strengthening. And this one is my favorite. Ah, so proud of her. All right, functional mobility for real, moving around in space. So I mentioned already where we started was getting into each position, prone, supine, quadruped, tall kneeling, changing between positions, back and forth, then trying to move in each position. Commando crawling is one of the hardest things that we can do. Bear crawls, forward and backwards and sideways. Again, we progressed up to this. Giving her some external cues in terms of her spacing. And anything that I'm showing where she's going backward, we did also do forwards. I just may or may not have video of all of it. And also don't have all the time to show all the videos that I was able to find looking at our many years of working together. But yeah, there's definitely research on there's research now on kind of falls training. I don't know if as much functional mobility research as I would like. All this movement around on the floor is just one of my favorite things to do. And in my experience as a therapist, it benefits people not only on the floor, but as we get up into sitting and into standing in different positions. It's a good research project. You know, what if you took someone with, you know, ataxia or balance impairment, and one group only did standing exercises and one only did mobility on the floor? Be very interested to see the comparison. Of course, in the real world, I don't think that we only should do one or the other, though. I think we should be doing both of those, but it'd be interesting to see differences. So crab walking, sitting and scooting. This, in many cases, is high intensity as well. So again, you can accomplish skilled training and high intensity aerobic exercise at the same time when you get people working at this level. Look at this sidestepping bear position, getting even a little bit of a hop. And again, I'd say just one of my most important things to me, knowing that I'm only with people for a short amount of time throughout the week, is giving them freedom to move, building their confidence, helping them learn how to figure things out, because that is the skill they need for all the time that we don't get to spend together. So like I mentioned, balance is more than standing exercises. I love here, the goal is to sit and, oh no, here we are working on transitions. Sometimes we do seated balance here where we rock back and hold that position. Here we're actually working on transitioning back and forth. At first, when we would do that, when she would roll back, she'd roll over onto her side and she couldn't control it. So here to be able to roll back and then come right back forward. Was a progression. Lots of work in half kneeling, which if you incorporate that into your own exercise program, you will feel the strengthening and challenge that comes from this position. Ooh, there's that one again. That's the same fall as before. Not an additional one. Here, any type of exercise that someone likes, whether it's dance or boxing, that can be incorporated into these different functional positions. Patty had loved doing kickboxing workouts prior to her first stroke. One more opportunity for really challenging balance at a high level, progressing from quadruped to a half, I don't know exactly what this is called, half quadruped. This one leg back really makes it much more challenging. I'm giving her the space to work through that. It's tough, but she's doing it. Okay, let me out of this video. Come on, presentation. Okay, there we go. All right, last examples. I also am a huge fan of straps. These are jungle gym straps. There's also TRX straps are very common. I do like the jungle gym though, because it's two separate straps and you could theoretically have them connected separately if you like. And you also can use them separately. So here, and I like them. They're supportive, but they're also dynamic. So there's a lot of ways that you can progress and actually reduce the amount of support that people are getting. Then fully moving up into standing with the straps, practicing stepping in different directions. Some high knees, some turns and listening. adding some twisting in. So one of the biggest areas I thought about is we definitely could add even more specific visual and gaze stabilization exercises into her routine. In many cases when we were exercising, she did have something that she was looking at, but that's something that I think that we could improve even more in terms of what we're doing with her exercises. So the summary, we still want to focus on what is a way that we can get high intensity aerobic exercise for this person so that we can help them have what they need for neuroplastic changes. We want to challenge balance at a higher level with support and a safe setup, work on functional mobility, learn to love the floor, do a lot of what they can do in home sessions and your sessions to make sure they can follow through and do them and that you're progressing them as quickly as they can handle. Start where they are at and progress over time. I realize that Patty, especially in these videos, looks very athletic. She is very athletic. She did not start there. This is where we were able to progress to. And you really don't know what people are capable of unless you challenge them at that really high level. And I know it's very natural to be fearful of things like safety because that is very important. We want to make sure people are not injured, but we as therapists also have to develop our skills to set people up in a safe environment, ideally get the equipment, if at all possible, harnesses and things so that we feel comfortable giving people more space so they can really problem solve through all this great work, because we will be able to help people more if we really have a good environmental setup for them and for us to feel comfortable challenging them at this really high level. Yeah, my slides do not want to progress forward. Okay, so want to keep this conversation going. This is the kind of brainstorming and video shares that happen in the NeuroSpark membership. So I'm going to turn it over to Erin so she can tell you a little bit more if you're interested in continuing this brainstorm with us on a regular basis.
Thank you, Claire and JJ. All right, let's keep it rolling. I have a great video to share with you as well, getting kicked off, but so fun seeing the chat and all of the questions and help that we're providing each other. I love seeing some of the things that you're putting in here because I know these are topics that we will address as many of the questions right now as possible. And I know that we have learning modules on those coming up inside NeuroSpark. So I'm going to talk a little bit about how to actually apply what you're learning. And just again, as a quick intro, I'm Erin Gallardo, a co-founder of NeuroCollaborative. I've been a PT for nearly 18 years, and I've worked in every setting, including as a clinic owner. And now I have the pleasure of working with fantastic clinicians and educators, and those of you out here designing unique neuro content and us producing these mentorship opportunities with a goal of elevating healthcare and your practice and your patient outcomes. So first, I want to show you a video of what that actually looks like in practice, because this is a really great visual example of how we can incorporate the things that we want to learn to really better our clients' experiences and outcomes. So this is a video that was shared by Tiffany Picayune. She's a PT in Southern California. She was a NeuroSpark member and created this video to show working with one of her patients. And you're going to want to turn the volume up a little bit on the video itself because let me make sure I shared my sound too for the video. It's not the loudest. It's not the loudest. It's not the loudest volume on the video itself. So just make sure that you turn up your volume. Okay, there we go. Optimize for video clip. Okay, cool. On the video. So I'm going to let Tiffany share her story.
Hi, my name is Tiffany Picayune. I'm a physical therapist. I've been a physical therapist for 27 years. I work in a little nonprofit outpatient neuro physical therapy clinic where we get to see people after their insurance runs out. And I thought I'd share a little bit with you about my journey with my buddy Scott. He had a traumatic brain injury about 12 years ago and came to us a little over a year ago with the major goal of getting back to ice skating and rollerblading, roller hockey. So we've been working on that. and I thought I'd share a bit of our journey and how NeuroSpark has helped us.
Got together, we just practiced this, right?
Yeah.
And together.
So obviously Scott is very ataxic. He was falling once or twice a week when he got to us. He really seeks end range and ligaments because they don't shake. And so much of our therapy has been focused on getting him mid-range dynamic control, kind of finding activities where he has to use dorsiflexion, he has to use knee flexion, get in that athletic stance, and really get some dynamic control there. And he actually shakes a lot less in that position.
Come back, just don't worry about it. Okay, now push your knee forward and move your hips over. Look at how good you're doing. Woohoo! Do it again. One more on each side. Beautiful, that's fine. Knee forward, push that knee forward. Knees soft, ankles bent. That's it. Whoop, chest bent. Knees soft, ankles bent. That's it. Push with the back foot, right on the right foot. You need to push with the right foot too.
And so this is where NeuroSpark came in. We learned a lot about airing the client to get some more progress. And I saw a lot of great new ideas from Claire and slips and trips and various things. And so we tried to put them all into good use and get a little more reaction time, a little more directional control for his front foot. And you can see, I think it's working.
Right leg out. Right leg out. Stand up. That's what he's supposed to do.
I know. Oh my God. It's taking me all this time to teach him not to stand up. Beautiful job, Scott.
So thank you, NeuroSpark. Scott and I are having a lot of fun, and we really appreciate your help.
Oh my gosh, I cannot get enough of that video. So amazing, the things that she's doing in there. And, you know, just an example of clinical excellence in practice. So huge thank you to Tiffany and Challenge Center. And, you know, she really embodies the 3 things that clinician experts have. So I'm going to talk about what those are. And it's not that it's just experience, because yes, she is an experienced therapist, but it's really not just that. No offense to them, but I'm sure you know of a clinician who's been practicing for a really long time, and you wouldn't consider them a clinician, an expert, or a master. So you don't just become an expert with time. There's something else that clinicians have who become experts. There's 3 traits. And it also goes beyond knowledge. A lack of information really isn't what's standing in the way of you showing your patients that their disease doesn't have to stop them from being independent. Do you know what is stopping them? Well, I'm going to tell you a story, and let's just see if you can relate to it. This is me as a baby clinician at Rancho Los Amigos some 15 years ago. When I was first starting out in the clinic in inpatient rehab, I thought I knew a lot of stuff. I mean, I definitely learned a lot of things in school, and I was taking over the caseload of a previous therapist, and I was about to work with a patient who had a diagnosis that I had never heard of. And I don't know, I'm sure that has happened to you, right? Can anyone relate? So my supervisor was going to go with me, and I think she was just trying to see what kind of therapist I was going to be. So we went to the patient's room and we got him out of the room to the treatment room. He needed a Hoyer lift, max assist transfer, got him on the big table, and I froze. And I just thought, oh my gosh, what am I going to do with this patient? He can't roll, he can't bridge. I don't know how to apply what I had previously learned in this situation. And I had this thought. I don't know if you've ever had a thought like this. I am not the right therapist for him. And I never wanted to feel like that again. I wanted to learn as much as possible about everything so that I could help every patient from then on. I really wanted to know how to be an expert, because I just thought if this patient were with insert whatever expert therapist, JJ or Claire or Jamie or Jennifer, they'd be much better off. And that's just not a very empowering thought to have. So I really wanted to know, what does it take to become an expert clinician and how soon can I get there? So I do what any dedicated therapist does, and I take courses after courses after courses, so many. And I love courses, and we all do. So no like dirt on courses. They're amazing. And it just wasn't until later that I realized there was something missing when it came to doing courses. Like, for one, I couldn't follow up with the instructor. So I'd learn a lot in a very short amount of time. And I just couldn't possibly understand and remember it all and apply what I was learning. I couldn't talk to anyone after the fact and answer my questions so that I could actually apply the knowledge in a way that would really be beneficial. So it was, this question, what do I need in order to become an expert clinician? So let's talk about that. That's going to take us to the 3 traits that experts have. So trait number 1 is wisdom. And wisdom goes beyond knowledge, because it's not just knowing things, it's knowing how and when to apply them. It's about making powerful decisions and being discerning with your choices. So you saw Tiffany in that video. Wisdom was there. She knew how to progress Scott. She knew when to challenge him in the right way, how to approach things and give him just the right amount of intensity that was very hard, but gave him progress. So that's trait number 1. Trait number 2 for expert clinicians is confidence. Oh my God, the amount of confidence she had in that video, rollerblading with him, was amazing. And confidence doesn't mean only that you know how to help anyone that's in front of you and you get excited about it, because that is true. It also means that you're open to other perspectives. You are intrigued. You approach every session with curiosity to see what you can learn, not just what you can teach. That's a huge trait. And then the third one is a powerful network. Now think of one master clinician who operates on an island, who doesn't have like-minded colleagues and peers and people who are better than them, people who are different than them. They all have this. They all have a community with a shared mission. And experts also give back to their peers and colleagues so that everyone is elevated, because that is how we all, including our patients, will win. And isn't that what you want for your patients to win? So the question is, how do you become an expert? The answer is mentorship focused on knowledge application. So what does that mean? Knowledge application mentorship is when you get new ideas and approaches, but they're also given to you in a way that's easy to learn and implement, where you can get feedback, you can try things, you can come back to the group or to whoever you're learning with and ask those questions. You can get the latest research broken down easily so you can apply it rather than needing to look everything up yourself, and where you can learn from each other and build each other up so that everyone is being elevated and being excited. Kind of seeing in the chat here, questions, mentorship, excitement, things that you're all learning together. And this is what helps you become an expert, so that now you can show every patient that their disease doesn't have to stop them from being independent or from living their full life or being fulfilled. Isn't that what you're looking to provide for your patients? I think you are. So if you are thinking this, you're now asking, how can I get mentorship that's focused on knowledge application? Well, there are ways to do this. If you have a lot of extra time in your schedule, you can read all the latest research as it comes out. There's only hundreds of articles published every year. You can search for a mentor who actually has time to go over your questions and give you feedback on an ongoing basis. You can build a community of like-minded lifelong learners like yourself who are dedicated to clinical excellence around you. But I don't know any busy clinicians who actually have time or flexibility to do that. Do you? So if you're ready to discover the secret to keeping up to date with the research, to having confidence in every patient session, and to discovering how to challenge your patients the right way every time, then you are ready for mentorship focused on knowledge application. And that's where NeuroSpark comes in. So we have some very exciting things coming up this central vision impairment with our OT, Brianna. And I already saw a question. Concerns. We have visual, we have motor, we have upper extremities. So Brianna's going to address that as well. And then chronic post-concussion considerations in the Vesti track with Christina Garrity. And another mentorship session. The opportunity to win this only. This will be at Rogue. It was so fun. We had our last one in October. Our next one